Hi, my name's Alexa Bonnicott. I'm a consultant nephrologist working in Cardiff and Vale and Near and Bevan, and I'm the clinical lead for CKD prevention for the Wales Kidney Network. Thank you very much for inviting me to talk this lunchtime to introduce our new Chronic Kidney Disease National Quality Improvement Programme. So our objectives for today, I'm going to give you a quick reminder of the national prescribing indicators that Shalia and Kat introduced at the last session, focusing on SGLT2 inhibitors in CKD. I'm also going to introduce you to a new All Wales resource, the Community Health Pathways page, to help with optimisation and guidance for CKD management. And we're going to discuss some fairly hot off the press GMS approved CKD quality improvement project for All Wales 25-26. So you're probably thinking, why are we hearing so much about CKD at the moment? You know, it's been around for ages, but why all the fuss all of a sudden? And this report here from Kidney Research UK is responsible for driving an awful lot of momentum UK-wide, because it reported on how kidney disease is a UK public health emergency, with 10% of the UK population having CKD and that number rising at a cost of 6.4 billion to the NHS, 1.7 of that in Wales. Diabetes, of course, is the leading cause of CKD, and CKD is associated with an enormously high cardiovascular morbidity and mortality. In fact, patients with CKD are 20 times more likely to die of their cardiovascular disease than they ever are to reach the need for dialysis in their lifetime. And that is a massively underappreciated factor for patients and healthcare providers alike. What about the situation in Wales then? Well, we know that our diabetes rates are rising. This is Public Health Wales data demonstrating a 40% increase in the last 10 years. Our end-stage kidney disease rates are also rising along with the other UK nations, but we are consistently higher than Scotland and generally higher than England as well. And we feel that on the ground with our haemodialysis units in Wales, particularly in the south and the west, really reaching maximum capacity. And we have, in fact, breached maximum capacity on a number of times in the last few years, which is a very, very uncomfortable position to be in when you are providing life-sustaining treatment for patients. And it's not cheap. We've got 1.6 thousand patients on some form of dialysis in Wales, and haemodialysis costs 35,000 per patient per year. But the other reason that you're hearing a lot about CKD is that there has been this sort of paradigm shift, really, in the management of CKD using these drugs, these SGLT2 inhibitors, of course, originally designed as diabetes medications for benefits in CKD, because we know now from renal dedicated trials of these agents that they can reduce the risk of CKD progression by a massive 37%, but they can also reduce the risk of cardiovascular death and hospitalization for heart failure in patients with CKD by 23%. And that is why we're seeing these really now starting to drive the whole cardiometabolic era of medicine, with NICE approving these drugs as gold standard of care right the way across the cardiometabolic spectrum. You'll see as well that SGLT2 inhibitors are one of the major steps in the Save 10,000 Lives in 10 Years strategy outlined by Kidney Research UK, point 3 here. But you'll also note that points 1, 2 and 3 is all really about better improvement in diagnosis, detection, early management, all of which is predominantly in the community sector. And we've done some work in the Welsh Kidney Network with HEOR, Health Economics Outcome Research, to look at how this might make an impact in the future in terms of our health economic benefits. And you can see that if we were to get all patients from CKD stage 3A onwards who are eligible on an SGLT2 inhibitor in Wales, we could save up to 15,000 lives in the next 10 years. We could save 45,000 QALYs, quality adjusted life years. And it would, of course, mean that because we are essentially putting the brakes on CKD progression with these drugs and delaying that end-stage kidney disease, that fewer patients will reach that in their younger years. That means they're able to go to education, they're able to work, they're able to contribute to the economy, etc. But what it will mean is, because we are keeping patients alive for longer who may otherwise have succumbed to their cardiovascular disease, that patients may be living long enough to reach end-stage kidney disease in their sort of late 80s, 90s. So whilst we're not massively reducing the overall numbers of end-stage kidney disease, we are changing that demographic for the better, potentially. So huge potential health benefits for patients in Wales. And I said I would remind you about the national prescribing indicators for Flozins. There are actually, there's a third indicator, and that's for heart failure and diabetes, but I focused here on the indicators for CKD. And we have indicators for patients with type 2 diabetes and CKD, and then separate indicator for patients with non-diabetic CKD. And remember that flozins have been shown to be equally efficacious in both of these groups. So non-diabetic CKD is by no means a weaker or lesser indication for these drugs. But I want to hone in on the unit of measure here. So for patients with type 2 diabetes and CKD, it's the number of patients who are currently treated with an ARB or an ACE, which is of course our sort of foundation basic renoprotective medication, who are then additionally prescribed an SGLT2 inhibitor. And for patients with non-diabetic CKD, it's the number of patients currently treated with an ACE or an ARB, but despite this still have an albumin-creatinine ratio of greater than 22.6, who are prescribed an SGLT2 inhibitor. 22.6 does seem like a bit of an odd number, but that is taken directly from the randomized control trials that were used of these agents. And the justification for these NPIs in these two different groups are shown here. So in patients with type 2 diabetes and CKD, they are at a very, very high risk of major adverse cardiac events and progression to end-stage kidney disease. If they additionally have albuminuria, which the vast majority of these probably will have, they are at even higher risk of these things. But you do not need an ACR criteria to prescribe. It is perfectly justifiable for a patient with type 2 diabetes and CKD to be offered a flozin on the basis of that very high cardiovascular risk. For patients with non-diabetic CKD, it is the raised ACR that puts these patients in a particularly high-risk group, and that is why the ACR criteria is included in that NPI for this cohort. Not included in this NPI, but I have included it here on the slide because it is mentioned in Community Health Pathways page and also in our quality improvement project that I'll get onto, is that group of patients who have a GFR of 20 to 45 with or without diabetes, irrespective of what albuminuria they have. So simply patients with a GFR of 20 to 45, by virtue of the fact that their GFR is already on the lower side and they are therefore at a higher risk of progression to end-stage kidney disease in their lifetime, they have an indication for a flozin. At the moment, that is empagliflozin via TA942, and there's more information about that on the Community Health Pathways, which I shall show you in a moment. But don't forget, of course, that many of these patients will also have coexisting heart failure, which is an indication for a flozin by itself. 30% of patients with heart failure will also have some sort of CKD. So I guess the message here is really to try and consider the patient across the entire cardiometabolic spectrum when prescribing these agents. And really, it's not about, especially in patients with CKD, their risk is so high that it's not really about justifying why you should be on a flozin. It's really about justifying why you haven't offered a flozin. You know, what contraindications are in existence that this patient should not be on a flozin. And to help embed this into practice and really try and drive that cultural change in identifying and optimizing early CKD, where we really stand to make the greatest gains in terms of reducing that cardiovascular disease and progression, we've developed an All Wales CKD page on the Community Health Pathways. So for those of you who aren't yet familiar with Community Health Pathways, this is an online guidance tool. It acts as a repository for quick reference information, management, referral pathways. It is designed for use predominantly by primary care, but it's also accessible to secondary care users as well. And this has been up and running in Cardiff and Vale now for quite a few years, but it is now being rolled out nationally. And groups like ourselves at the Welsh Kidney Network have been collaborating with primary care to write these pathways, and the intention being that we're sort of minimising that regional variation and making sure we're all following best evidence-based care and including our own AWTTC prescribing advice, of course. So this is what the pathway looks like. This is what the page looks like. You can see that there is, I've scrolled down to nephrology. Not all of these subtitles are actually populated yet. But you can go into a little bit of background about CKD. It moves you into assessment. There are lots of drop-down boxes for things like risk factors and so on. And then you move into sort of the management of CKD in a stepwise pathway. Again, you can look into blood pressure targets, lipid targets for these patients. And then we've got the information on ACE inhibitors and the flozins, of course, with direct links to the individual NICE TAs for the drugs. And we also have prescribing points, which are sort of the do's and don'ts for prescribing. And we've also got the sick day rules that are available in both English and Welsh as downloadable leaflets. And then it moves into sort of how to request secondary care referral, whether that needs to be urgent or routine, when they might be better directed to urology, and then finally some information for health professionals and for patients as well, a number of links there that are available. So I don't have a date when this is going live. This is currently the draft page, as you can see, but I have been told that it should be anytime soon. So I may be able to give you a bit more of an update on that in the question and answer session. And the General Medical Services in Welsh Government have really got behind this CKD prevention agenda. And as I say, very, very recently announced that this will be one of 3 quality improvement projects that will be financially remunerated via the new GP contract in 25-26. So it's a bit of a busy slide, but the targets are essentially as listed here. But the intention is that practices will sort of use this as a menu of options to apply some, all of these, depending on what they assess their specific practice population needs are. So for some, for example, it may be a big push on ACR screening rates. For others, it may be more about the bottom point there in getting all of their practice members educated via a new e-module that is currently being approved by HEIW. But what we do hope is, with the added incentive of the national prescribing indicators, we do hope that it will ensure that the primary goal of this quality improvement is met, and that is to improve drug optimization of CKD with the SGLT2 inhibitors. And of course, the usual principles of quality improvement will apply, and practices will be expected to demonstrate that PDSA cycle and report their outcomes as a poster in a session in March 2026. In terms of the implementation and recording for this quality improvement project, DHCW Digital Healthcare Wales are currently beavering away to produce a set of predefined searches that are going to accompany the quality improvement project, and we hope will allow practices to be able to collate an accurate register of CKD. In other words, find patients who may not be coded or who may be mislabeled CKD3 when they're actually stage 4, but also to be able to identify patients who fall in at-risk categories, so those that may have codes for diabetes, hypertension, patients who've been on lithium for a long time, etc. It's obviously going to be able to identify the target CKD populations for those blood pressure targets, medication optimizations, and in particular compare the Flozin and prescribing rates, and be able to do that against other practices, other clusters, which can already be done via the Diabetes Audit Plus module, but not specifically for CKD, so that's an added dimension. And of course, we hope that these searches will enable practices to measure the outcome of their quality improvement interventions easily. In terms of where this will live, the fine detail in this is all to be confirmed, but the Primary Care Information Portal, which I'm sure you will all be familiar with, is where we are going to be hosting most of this. So it does already exist, believe it or not, but actually only probably renal nerds like myself have accessed it in the last 5 years. It lives within this page, the modules, chronic conditions. If you click on that box, it opens up your chronic condition modules, and you can see that one of those is the National CKD Audit. So this is a bit of a hangover from a project that was done in about 2016, but Audit Plus still pulls data into this module. It is old, it is clunky, and some of the parameters are not quite up to date. So, for example, there's no information on Flozins at the moment. And so these are all being added as we speak, and will hopefully mean that there will be a set of searches that will make this really easy for primary care teams to perform this quality improvement project. I believe as well there may also be downloadable, importable searches specifically for EMIS, but the number one tip would be that the Primary Care One quick page will be where all of this information will be released as and when it is ready. So in summary, CKD, we've learned, is a major problem in Wales. 1 in 10 adults have CKD and the incidence is rising. CKD and albuminuria independently is associated with a very high cardiovascular morbidity and mortality, and that is under-recognised and underappreciated. But early detection and optimization with Flozins can delay CKD progression, reduce major adverse cardiac events and heart failure, with the potential to save up to 15,000 lives in Wales in the next 10 years. And we hope that the new Community Healthways CKD pathway page, which will be available to all NHS users, will provide that guidance and support to help prioritise this. And I mentioned that Wales is the first UK nation to deliver national mandates and financial incentivisation to prioritise CKD via our national prescribing indicators and the Primary Care Quality Improvement Project. And please, a reminder that for any updates and all the resources that will be required to support implementation of the QIP, please do visit the Primary Care one page. Thank you very much for listening. Please feel free to fire any questions at me now, or if you'd rather, email me on the contact below and I'd be happy to chat about this. Thank you very much.